A landmark study involving over 19,000 patients found that one simple change was linked to a major reduction in heart-related deaths. No new medication, no higher dose, no special diet or exercise. The same blood pressure pill, just taken at a different time of day. And within days, the body gained better protection during the most dangerous hours of the morning. I'm Dr. Amelia Carter. I work at the intersection of functional medicine and vascular biomechanics, which means I study how your cardiovascular system actually behaves across a 24-hour cycle. Not just the snapshot your doctor gets at a 1 p.m. appointment, the full living dynamic picture. And what I'm about to share with you is something that the research has been pointing to clearly, but that almost never makes it into the average doctor's appointment. Stay with me, because by the end of this video, you are going to understand your blood pressure medication in a way that most people, including many physicians, simply do not. Before we go any further, I need to say something important, and I mean it with complete sincerity. I am a doctor, but I am not your doctor. Please do not change the timing of any medication you are currently taking without first speaking to the physician who prescribed it. Some blood pressure medications have specific reasons they must be taken in the morning. Some have interactions or side effects that make timing critical for your individual situation. What I want to give you today is knowledge, the kind of informed, evidence-based understanding that helps you have a genuinely productive conversation with your own doctor, not a replacement for that conversation. Use this video as your preparation, then pick up the phone or walk into that appointment armed with the right questions. That partnership between an informed patient and an attentive physician is where the real breakthroughs happen. Now, let's talk about what's actually going on inside your body every morning. Here is something that surprises almost everyone when they first hear it. Your blood pressure right now, sitting where you are, is not the same number it was 6 hours ago. And it will not be the same number 6 hours from now. Your blood pressure is not a fixed measurement. It is a living wave, a 24-hour rhythm that your cardiovascular system runs on like an internal clock, rising, falling, surging, and dipping in response to hormones, activity, light, food, and sleep. Let me walk you through a typical day in your cardiovascular system, and as I do, I want you to notice how many things you'll recognize from your own experience. Mid-afternoon, around 2 p.m., have you ever felt a wave of heaviness after lunch? A slight sluggishness, like your energy dropped without warning? That is real. That is your blood pressure naturally dipping as your body redirects circulation toward digestion. The pressure in the rest of your system drops slightly. You feel it as that familiar post-lunch heaviness. Your body is not failing you. It is doing exactly what it is designed to do. Late afternoon, around 4 to 5 p.m., have you ever noticed a second wind in the late afternoon? A moment where you feel like going for a walk, tackling something on your to-do list, making a phone call you had been putting off? That is your blood pressure rising to its second daily peak. Your body is giving you one more push before evening. That energy is biological. It is real. And now, early morning, between 4 and 10 a.m., the moment that matters most. The moment that may have been quietly shaping your mornings for years. In the hours between roughly 4 a.m. and 10 a.m., your body undergoes what cardiovascular researchers describe as a morning surge. Your stress hormones, primarily cortisol and adrenaline, begin flooding into your bloodstream before you even open your eyes. Your blood vessels constrict, blood becomes slightly more viscous, thicker, and stickier. Your heart begins pumping harder and faster. This is not a malfunction. In evolutionary terms, it is your body preparing you to wake up, stand up, and engage with the day. But the consequences of this surge are significant. Research consistently shows that approximately 40% of all heart attacks occur during this morning window, around 49% of all strokes. The peak of sudden cardiac events clusters between 7 and 9 in the morning. This is not random. This is biology. Your body creates a set of conditions, elevated pressure, thickened blood, constricted vessels, that when combined represent the most cardiovascular stress your system faces in any given 24-hour period. And your blood pressure medication is supposed to be there, standing between you and that storm. But for millions of seniors who take their pill with their morning coffee, it isn't. Here is the timing problem laid out simply. If you take your blood pressure pill at 8 a.m., which is what the majority of seniors do because that is what they were told, here is what happens over the next 24 hours. The pill enters your bloodstream and reaches effective levels in your system by roughly midday. It protects you through the afternoon, the very time of day when your blood pressure is naturally lower and you need less protection. By evening, it begins to decline. By midnight, it is fading. By 3 or 4 in the morning, it is nearly gone. And then the morning surge arrives at 5 a.m., the most dangerous period of your cardiovascular day. And the medication meant to protect you is at its lowest point in your entire 24-hour cycle. This gap between when the pill wears off and when the morning storm arrives is something that has been documented in the clinical literature. And it is something that a single practical change in timing has been shown to significantly address. Now, I want to introduce you to someone. His name is Henry. I'm sharing his story today with identifying details changed to protect his privacy because his experience captures something that I believe is happening in countless homes across this country. Something that no blood test, no afternoon appointment, and no chart notation ever revealed. Henry was 68 years old, a retired baker from a small town in Pennsylvania. For 40 years, Henry had woken at 3 in the morning to fire the ovens. He kneaded dough by hand, sourdough, rye, pumpernickel, and he could tell by the stretch of the gluten between his fingers when it was ready. He fed his entire community before most people opened their eyes. When Henry retired, his wife said he would go crazy without something to do with his hands. She was right. He built a greenhouse behind the house. Glass walls, wooden benches. A misting system he installed himself. He grew orchids, not the kind from a grocery store in a plastic pot. Rare ones. Competition grade. The kind that bloom once a year if every detail is exactly right. Temperature, humidity, light angle, the precise moment to prune. Henry's orchids won 3 regional awards. His greenhouse was, in his own quiet way, his cathedral. Every morning at 5 a.m., while the sky was still dark, he would walk across the wet grass in his slippers and open the greenhouse door. The air inside was warm and damp and smelled like earth and flowers. He would pick up his tiny pruning snips, blades the size of a thumbnail, and study each plant the way he used to study dough. By feel, by instinct, by the patience of a man who had spent a lifetime working before dawn. Henry took his blood pressure medication every morning at 8 a.m. with his coffee. His doctor told him his blood pressure was well managed. His afternoon appointments consistently showed readings in the healthy range. His chart said everything was fine. At 5 a.m., nobody was measuring. The headache started gradually. Every morning, around the time he walked to the greenhouse, a dull, heavy pressure at the base of his skull. Not sharp, not dramatic, just a vice grip, slowly tightening. His heart pounded so hard he could hear it in the pillow. His hands trembled when he reached for his coffee mug. He went to the greenhouse anyway. He tried to work. One morning, reaching to trim a small dead leaf from a stem no wider than a pencil lead, his hand shook. The snips slipped. He cut through a healthy stem on an orchid he had been cultivating for 14 months, gone in 1 second. He put the snips down, walked back inside, sat in his recliner in the dark living room, and waited. Waited for 9:30, 10 a.m., when his pill finally kicked in, when the headache faded, when his hands steadied. By then, the morning was gone. This became his routine. Wake at 4:30, feel the vice grip arrive, sit in the recliner, wait, miss the morning. His wife would find him there every day, jaw clenched, fists white on the armrests. She stopped asking if he was okay. She just brought him coffee and sat across the room in silence. She told their daughter she felt like she was losing him, one morning at a time. Henry was not getting old. Henry was living inside the gap between when his medication wore off and when the morning surge arrived. And he had been living there, unprotected, for 6 years. His doctor never knew, because his doctor always saw Henry at 1 p.m. At 1 p.m., his medication was at full strength. His readings were perfect. His chart said he was managed. His morning said something entirely different. So why did morning dosing become the universal instruction in the first place? The answer takes us back to 1955. The first blood pressure medications developed in the mid-20th century were powerful diuretics, water pills. They worked by making patients urinate heavily to reduce fluid volume and lower pressure. If a patient took one of these pills at night, the consequences were obvious and problematic: disrupted sleep, falls in the dark, genuine safety concerns. So, physicians logically, reasonably, appropriately told every patient the same thing: take it in the morning. That instruction made complete sense for that medication in that era. But medicine evolved. Through the 1980s and 1990s, a new generation of blood pressure medications was developed: ACE inhibitors, ARBs, calcium channel blockers. These medications work through entirely different mechanisms. They do not cause significant urination. The original reason for morning dosing, protecting patients from nighttime bathroom trips and falls, simply does not apply to them. But the instruction was never updated. Take it in the morning traveled from generation to generation of physicians like a family recipe that nobody questions. It outlived the reason it was written. Henry's medication did not make him urinate. There was no physiological reason it needed to be taken at 8 a.m., but that is what he was told, and like every trusting patient, he followed the instruction without knowing the history behind it. There is another dimension to this story that I want to make sure you understand, because it affects up to half of all adults over 65, and most of them have no idea. In a healthy cardiovascular system, blood pressure does something important while you sleep. It drops, typically 10 to 20% below daytime levels. Cardiovascular researchers call this the nocturnal dip, and it is not a passive event, it is an active, essential maintenance process. During that nightly dip, your heart gets to genuinely rest. Your kidneys process fluid more efficiently. The tiny blood vessels in your brain, the ones responsible for memory, focus, and cognitive sharpness, get a low-pressure window that allows them to recover from the demands of the day. In younger, healthier cardiovascular systems, this dip happens automatically. The nervous system eases off the accelerator. The blood vessels relax. But with age, and particularly with chronic stress, inflammation, and vascular stiffening, this mechanism weakens. For a significant proportion of seniors, the nocturnal dip simply stops happening. Blood pressure stays elevated through the night with no recovery window. The heart never truly rests. People in this category are called non-dippers in the clinical literature, and research suggests that non-dippers face substantially elevated risks of silent vascular damage, particularly in the small blood vessels of the brain, compared to those whose blood pressure dips normally at night. Here are 3 signs that may suggest your blood pressure is not dipping at night the way it should. I want you to notice whether any of these feel familiar. First, waking 2 or more times per night to use the bathroom, when your bladder feels relatively empty. This can sometimes be your kidneys actively working to reduce fluid volume in response to elevated nighttime pressure. Not a bladder problem, a pressure problem. Second, waking with puffy ankles that improve by midday. When blood pressure remains elevated overnight, fluid management is compromised. Overnight swelling that resolves with movement can be a signal worth discussing with your doctor. Third, waking with a dull, heavy ache at the base of your skull that fades by mid-morning. This pattern, the morning headache that disappears as the day progresses, is something Henry knew intimately. It reflects the morning pressure surge hitting vessels that never got their overnight recovery window. If any of these feel familiar, please bring them up at your next appointment, not as alarm, but as information. Your doctor cannot see what happens at 4 a.m. unless you tell them. Now let me tell you about the research, because I want to give you the complete, honest picture, not a cherry-picked version. A landmark study, known as the High-GIA chronotherapy trial, followed over 19,000 patients across 6 years. Half took their blood pressure medications in the morning. Half took them at bedtime. The results from the bedtime group were striking. Significantly fewer cardiovascular events, including deaths from heart-related causes, non-fatal heart attacks, and strokes. These numbers generated enormous attention in the cardiovascular research community, but science demands replication. And a subsequent large study, the TIME trial, conducted in the United Kingdom with over 21,000 participants, found no significant difference in major cardiovascular outcomes between morning and evening dosing. Two large, serious studies. Different conclusions on the primary cardiovascular outcomes question. Here is what both studies agree on, and this is the part I want you to hold on to. Evening dosing of these medications is safe. The UK study confirmed clearly that taking blood pressure medication at bedtime does not increase fall risk, does not cause dangerous nighttime pressure drops in typical patients, and does not cause harm. So at minimum, the evidence says this: for the right medications, in the right patients, evening dosing is equally safe as morning dosing. And for patients who are non-dippers, whose blood pressure stays elevated through the night, there is a clear, logical, physiological rationale for why evening dosing may offer additional benefit by providing medication coverage during the hours when the body needs it most. The conversation is worth having with your doctor. The research supports having it. Now, and this is critical, not all blood pressure medications are the same, and this distinction genuinely matters for your safety. Medications that research suggests may benefit from evening dosing and that your doctor may consider switching include ACE inhibitors, the class that includes medications like lisinopril and ramipril, and ARBs, which include medications like losartan and valsartan, as well as calcium channel blockers such as amlodipine. These medications work by blocking specific hormonal and vascular pathways that are most active during the nighttime hours and the early morning surge. Medications that should generally not be moved to bedtime without specific medical guidance include diuretics, the water pills. Moving these to bedtime means significant urination through the night, which disrupts sleep and, critically, creates fall risk during dark bathroom trips. A fall at 70 or 75 carries consequences that far outweigh blood pressure timing benefits. If you are on a diuretic and want to explore timing, ask your doctor about a late afternoon dose, typically around 4 or 5 p.m., which allows the diuretic effect to complete before sleep. Beta blockers, which slow the heart rate, require individual assessment because your heart naturally slows during sleep. This is a conversation specifically for your physician. So here is your practical step. Go to your medicine cabinet. Look at your pill bottles. Identify what class of medication you are taking. The label or the accompanying information sheet will often tell you, and your pharmacist is an excellent, accessible resource. Then bring that information to your next appointment. And here are words you can use not to pressure your doctor, but to open a genuine conversation. Doctor, I have been reading about blood pressure timing and the morning surge. My morning blood pressure readings at home seem higher than my afternoon numbers in your office. I was wondering whether the timing of my medication might be worth discussing and whether there are any reasons specific to my situation why it should stay at its current time. That approach respects your doctor's expertise, provides them with useful information, and opens the door to a real conversation. If your doctor says the timing should stay as it is, trust that. They know your full medical history. But the conversation itself is always worth having. Beyond medication timing, there are 4 common habits that research suggests can actively undermine your blood pressure's natural nighttime recovery, regardless of when you take your pill. And some of them are going to surprise you. The first is aged cheese in the evening. This one surprises almost everyone. Aged cheeses, cheddar, Gouda, blue cheese, contain naturally occurring compounds that can trigger a release of stored adrenaline from nerve endings. This adrenaline causes blood vessels to constrict and heart rate to increase, precisely the opposite of what your body needs as it tries to enter its nighttime dip. Research suggests this effect can add several points to overnight blood pressure in sensitive individuals. If you enjoy evening cheese, switching to fresh varieties, mozzarella, ricotta, cottage cheese, avoids this mechanism entirely. The second is sleeping flat on your back. When you lie completely flat, gravity allows soft tissue in the throat to shift backward, narrowing the airway. Even subtle reductions in airflow trigger the brain's alarm system, a small burst of adrenaline, vessel constriction, a micro-awakening that you may not consciously register. This can happen dozens of times per night, keeping your stress system quietly activated through hours that should be restorative. Sleeping on your side or elevating the head of your bed slightly can meaningfully reduce these episodes in many people. The third is large water intake at bedtime. Many people take their evening pill with a large glass of water, 12 to 16 ounces. The consequence at 2 a.m. is a full bladder, a trip to the bathroom, bright light exposure, and a disrupted sleep cycle. The stress system reactivates. Blood pressure climbs back toward daytime levels. The recovery window closes. Taking your evening pill with just a small sip of water and doing your primary water intake earlier in the evening preserves deep sleep and the pressure dip that comes with it. The fourth is evening news before sleep. This may be the most culturally normalized saboteur on the list. The evening news is, by design, stimulating. It activates the brain's threat detection system. Stress hormones rise, blood vessels constrict. When this happens in the hour before sleep, the nervous system carries that activation into the first hours of the night. Turning off stimulating content by 8 or 8:30 p.m. and shifting to something genuinely calm, a book, quiet conversation, gentle music, allows stress hormone levels to decline naturally, setting the stage for the blood pressure dip your heart needs. Henry had two of these working against him every single night: sharp cheddar with crackers, the late news until his eyes closed. His medication timing was the primary issue, but these habits were reinforcing the problem from the other direction. Henry's daughter is a nurse. She came for Sunday dinner one afternoon and asked him a simple question. "Dad, what time do you take your medication?" He said, 8 in the morning, with my coffee. Haven't missed a day in 6 years. She asked, "And when do your headaches start?" 5 in the morning. Every morning. She put her fork down. "Dad, your medication is gone by 5 a.m. It wore off hours before you woke up. Your blood pressure is surging with nothing to slow it down. That headache is the surge." Henry stared at her. 6 years of mornings lost to a recliner. 6 years of watching his greenhouse through a window instead of standing inside it. 6 years of his wife sitting across a dark room, watching his fists clench, unable to help. And the answer was not a new drug. Not a procedure, not a different diagnosis. It was moving the same pill from 8 a.m. to 9 p.m. His daughter called his doctor, explained the pattern, the morning readings versus the afternoon readings, the symptom timing, the clinical reasoning. His doctor agreed to switch the medication to bedtime. It was not a diuretic. There was no safety concern with the timing change for Henry's specific situation. She also suggested he stop the aged cheese after 6 p.m. and turn the television off before 8. Henry took his pill at 9 p.m. that night. Day 2. He woke at 4:30 a.m., sat on the edge of the bed, waited for the vice grip. It didn't come. A slight heaviness behind his eyes, but no crushing pressure, no pounding heart, no shaking hands. He stood up. The room stayed still. He walked to the kitchen, made his coffee. His hands were steady around the mug. The house was quiet. The sky outside was still dark. The morning was his. Day 3, he checked his blood pressure at 5 a.m. with the home cuff his daughter had brought him. The reading was lower than anything he had seen at that hour. Ever. Day 5. At 5:15 in the morning, Henry walked across the wet grass in his slippers. He opened the greenhouse door. The warm, damp air hit his face. Earth and flowers and humidity. He had not smelled this in months. He picked up his pruning snips, looked at a phalaenopsis orchid he had been nursing for 2 years. A single dead leaf, the size of a fingernail, on a stem no wider than a pencil lead. He reached out. His hand did not shake. He trimmed the leaf with one clean cut. The snips closed with a tiny click. The leaf fell onto the wooden bench. He stood there for a long time. Not because anything dramatic happened, because nothing happened. No headache, no tremor, no vice grip, no fear. The morning was his again. Week 2, his wife stopped finding him in the recliner. He was in the greenhouse when she woke up, dirt under his fingernails, a look on his face she hadn't seen in 2 years. She said, "You seem like yourself again." He looked at her and said, "I am." Week 3, Henry noticed something he hadn't expected. He remembered things. His reading glasses were where he left them. He walked into the kitchen knowing exactly why he was there. He called his grandson by the right name without that half-second pause. His wife noticed before he said anything. She stopped finishing his sentences. She stopped reminding him of appointments. One evening at dinner, she looked at him and said, "Your eyes are different." He said, "What do you mean?" She said, "They're clear." His brain had been living under sustained nighttime pressure for 6 years. The tiny vessels that feed memory and focus had never been getting their recovery window. What everyone around him had quietly begun attributing to aging was pressure. Relentless, unrelenting nocturnal pressure that stopped the moment his medication was present when it needed to be. At his next appointment, Henry brought a notebook, 2 columns, morning readings and evening readings, 2 weeks of data. His doctor looked at the morning column, looked up. "Henry, these are the best morning numbers I have ever seen from you." Henry said, "That's because you've never seen my morning numbers before. You always measured me at 1 in the afternoon." His doctor ordered a 24-hour ambulatory blood pressure monitor. The results confirmed what Henry had already felt in his hands and his head. He was dipping at night. His morning surge was blunted. His heart was resting. 3 months later, Henry entered one of his orchids in the regional competition. A cattleya he had been nursing back from near death since the headache started. It had not bloomed in 2 years. With his mornings restored and his steady hands back in the greenhouse, it produced a single enormous bloom. Deep purple, white throat, second place. When they handed him the ribbon, his hands did not shake. His wife was standing beside him, not holding his arm, not watching for signs, not finishing his sentences, just standing there, watching her husband be the man she married. All he did was move a pill. Let me leave you with the clearest possible summary of what we covered today. Your blood pressure is not a fixed number, it follows a 24-hour wave. And the most dangerous point of that wave, the morning surge, occurs precisely when a morning-dosed medication is at its lowest level. The research is not unanimous, but it is consistent on one thing. For the right medications in the right patients, evening dosing is safe. And for patients who are non-dippers, whose blood pressure stays elevated through the night, there is a clear physiological rationale for the timing shift. But here is what I most want you to take from Henry's story. Henry's doctor was not negligent. Henry's doctor was a good physician following standard protocol. The issue was information. Henry's doctor was only ever seeing afternoon readings. Nobody was measuring the mornings. Nobody was connecting the headaches, the tremor, the bathroom trips, the ankle swelling, the memory fog, to a blood pressure pattern that an afternoon appointment could not reveal. Your doctor cannot see what happens at 4 a.m. unless you bring it to them. So here is your action plan. For the next 2 weeks, take your blood pressure at home, both in the early morning before coffee and activity, and in the afternoon. Write both numbers down. This data is more valuable to your doctor than a single office reading. Bring that notebook to your next appointment. 2 columns, 2 weeks. Let the numbers speak. Ask the question. Use the words I gave you. Doctor, I have noticed my morning readings are higher than my afternoon ones. Is there any reason specific to my situation why the timing of my medication should not be discussed? And review the 4 nighttime habits: evening aged cheese, sleeping flat, large water before bed, stimulating content right before sleep. These cost you nothing to address, and the evidence for their impact on nighttime blood pressure is solid. Your blood pressure medication is one of the most powerful tools you have. Don't let a 70-year-old instruction decide when it works for you. Those 2 answers, shared publicly, might be the exact thing that prompts the next person watching this video to have a conversation with their doctor that changes their mornings forever. If this gave you something valuable, share it. Text it to someone who takes their pill with their morning coffee. Someone whose doctor says everything looks fine at the afternoon appointment. Someone who sits in a recliner every morning waiting for a headache to pass. They deserve to know what Henry knows. Subscribe if you haven't yet. I'm Dr. Amelia Carter. Thank you for spending this time with me. Take care of your heart. Take care of your mornings. Take care of yourself. See you next week.